As a professor at Johns Hopkins, you spent 16 years. Tell us how we're addressing health equity at that level, at the getting the folks before they go into the field. Are we teaching them some of the skills again that we've talked about with you that are innate? Are we teaching the skills that are needed to effectively address health equity at the academic level in academia?
So I was part-time faculty at Hopkins for 16 years. I ran a lecture series and taught some public policy courses. So I wasn't, full-time there because I couldn't do anything else if that was the case. I think that's happening more and more. The disconnect is that academic medical centers often their faculty, even their physician faculty, don't really have clinical experience, or in some cases never had clinical experience. They got their MDs, but they never really were involved in patient care, and I think they miss a beat there because it's not how, academia doesn't always translate into day-to-day medical care, and it often doesn't translate into legislative action. And there is a disconnect. So you have brilliant people doing great research and studies, but it doesn't always connect with immediately what's happening in the legislative process or with active clinical care. So you can say, well, evidence-based medicine says this or the study says that, but then to actually turn that into a situation where there's a physician in an emergency room or a primary care doctor having to make some decision, it's pretty far. We need to bring the academic world and the research world closer to the clinical world and the political world in a functioning way. But they're different languages. Sometimes they're like ships passing in the night. Everybody's well intended, but they just don't know how to connect with each other. I did the best I could with some success and some failures to try to bridge those gaps.